When you are diagnosed with prostate cancer, you want to know a few things. You want to know, how aggressive is this cancer? How aggressive is it where I may or may not be a candidate for active surveillance, no medical treatment necessary? Or is it life threatening? Today's conversation is with one of the key scientists behind a genomic test called Decipher, Elai Davicioni. Dr. Davicioni is a graduate with his doctorate degree in pathobiology from the University of Southern California, USC, and is the medical director of the prostate section of Veracyte, the developers of Decipher, the Decipher test. In our conversation with Eli, we went through the full spectrum of genomics. What is it? What are we looking for? What does it mean? And specifically for prostate cancer, what are they testing for? Who's the right candidate to get a Decipher test? What are we looking for? It is a tremendous honor to have this conversation with Eli, who's a scientist, and he would admit he doesn't do podcasts, and he decided to be on this one. So I'm honored that Eli is on this podcast, and I think you are for a treat because you're going to learn a lot about genomics and the Decipher test and how it can help you, if God forbid, diagnosed with prostate cancer, determine what's the best approach for you and your physician. Please join me in welcoming Dr. Elai Davicioni. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. And now, I'd like to acknowledge our three amazing sponsors that you will hear about throughout this podcast. One is XY Wellness, a company I'm very familiar with as co-founder and medical director, a lifestyle company, XY Wellness, specific for men with prostate cancer. Next is Veracyte, the makers of Decipher, genomic test. After a biopsy or even a prostatectomy, you want to know how your cancer may behave. This is how the genomic test Decipher can help. Third, ExoDX. Prior to having a biopsy, you want to know if you really need one. And the ExoDX test, a urine test, is very helpful to determine if you need a biopsy or if you don't. Thank you to today's sponsors. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo. And you know what we do here? We try to optimize prostate health, figure out what to do with prostate cancer, things like testosterone, erections, independently, or the interaction of the three, and even how to live better with age as men. Today is, special in many ways because I have a true luminary in the space of genomics, particularly for prostate cancer. He's developed a test called the Decipher test that probably many have about by now. And he was just being honest before. He says, look, I don't do podcasts. So in order for him to even be here today is such a big deal. And I'm really honored to have you. Eli, thank you so much for being on. I can't tell you how much I appreciate it.
Thanks for having me. I'm a shy person. Okay.
Eli, tell me, like a lot of scientists, right? It's almost like also like computer engineers and things leave me out of the limelight, leave me in front of the computer or in my lab, and that's your happy point. So I'm going to bring out a little bit more extroversion of you, if I will. I'll try anyway. I really appreciate you being on. I know that you don't do these kinds of things. Eli, take me back. Take me back a little bit. You developed this test that I tell you, I bank on this test as a clinician, and many of my colleagues do as well, with regards to helping our patients figure out what they really have in terms of prostate cancer and even what are the next steps. When did this start for you? Were you like 20 something, 25 years old in a lab, looking at it in a petri dish and looking what are the genomics for, take us back and understand my audience even if they're physicians, I have quite a few physicians, they still don't understand how all this works.
Actually, like a lot of people don't know this, but a lot of oncology actually started in the pediatric space. And that's
Hmm.
also how we started. Basically, we were doing more or less the same thing as Decipher, but for pediatric sarcomas. And this was during my PhD. I wasn't 25, I was a bit older than that because I went to do the PhD a little bit later. But when we started, there was already a lot that had pioneering work that had been done in breast cancer. So when we started in prostate cancer, we felt breast cancer is 20 years ahead of us. And they, on some level, I mean, I think they still are. So we're trying to rapidly play catch up. Partly it's our fault as men, not
Exactly.
advocating and not being as involved as women, kind of advocating for this. But
Yeah, I
we
always
went,
feel like we're behind breast cancer and prostate cancer, Eli. I mean, I always
yeah.
feel like they're, several steps ahead of us. In fact, in my research, and as you remember, I practice primarily integrative and holistic urology and prostate cancer. I have to look at breast cancer research to sometimes even extrapolate for prostate cancer, since the
Hmm.
both cancers work in a similar fashion, right? I
Right.
always say breast cancer and prostate cancer are like cousins. So I always look at that research because I'm in the trenches, like just like everybody else. I don't have the time for a 20-year study. The patient
Hmm.
needs an answer now, and then we try to guess or make things useful from the breast cancer research. So when did the focus on prostate cancer start developing, and how long did it take before we had access to it for clinical use?
It took a long time, in part because when you do a PhD training, they don't get training on how to start a business, and it's just different. So
Yeah.
it's going in academia, trying to get grants and things like that. There's some similarities. So the company we started January of 2000, and I think the product, maybe the first patient that we tested, but under a research setting, was maybe about 4 years later. And then the product was on the
Hmm.
market in 2013. But it took us just getting a product to market. We didn't have the money to market it. So that was like, it took a lot longer than that before it became adopted and used. And it also just takes a long time to develop enough evidence. So people start using it a little bit. It's kind of a curios, and then they use it more as there's more evidence supporting its use, which is really the way it should be.
Right. Look, the way I feel with the Decipher test is that you guys were very patient with the process, took your time, build a really good foundation. I feel like the company works very well. It's a very high quality product, but the whole company functions really well. To then, in other words, you were in the long game, not the short game. You didn't want to just kind of, all right, here's the test without good evidence and just look at the financials of it and making a business out of it. You guys took your time and did it right. And I think that's why, you're successful and the business is successful, I assume, because we're using it and it's just, again, very valuable. It's even part of the NCCN guidelines now as a 1B evidence, which is amazing. You've never seen that in too many biomarkers or genetic testing. So
Yeah.
I admire what you guys have done.
Yeah, I think again, coming back to the pediatric space, most companies they bring their technology and they partner with academics, with leading researchers, but it's still a little bit standoffish. And we went
Yep.
more like how it was done in the children's oncology group, where it was more mass collaboration approach. And that meant sharing data and not just keeping it locked in a little, company lockbox. And I think
Yeah.
that's, yeah, that kind of one collaboration leads to another. And yeah, and you're absolutely right. It's not to do anything big in medicine. It's a generational effort, right? So I wish the
Yep.
politicians would think on the generational time scale for doing stuff. But yeah, medicine,
That's
you
a very
need to
good point.
be, yeah, thinking like 20, 30 years because this takes time.
And
Yeah.
patience, right? It teaches you patience, just like having children. I don't know if you have children, but having
Yeah.
children teaches you
Yeah.
patience. I'm sure being a scientist
Love.
with a novel technology and novel biomarkers, it teaches you patience as well, right?
Yeah. I thought it would happen a lot faster. So I thought that we could be on the market in a year. I was thinking like a tech person more because like it was I was influenced, I guess, by all of these startups, the dot-com era, and people would just I had friends that started companies and in 3 years they sold it. So I also thought maybe that's what happens. But then it's actually the journey is the fun part, and it still is the fun part. And then, like, it's not the end, it's the journey that you have to just savor and appreciate hard on a daily basis to always remember.
Having spoken to you, Eli, yeah, exactly. Having spoken to you not that long ago at the AUA, which is where we met in San Antonio, I felt connected to you in many ways. One is because you talk about the journey, and we just geeked out on testing and the importance of it and the details of it. And you could tell that's part of the journey. Yes, it's a business. Everything is a business. I run a business. But in my
Yeah.
perfect world, I would like somebody else to run the business, not think business. I just want to think clinical. How can I have more impact on patients' lives? And that's the journey I'm in. It's very interesting talking to you that, look, you're a scientist, but you had to put on your business hat and say, I don't know, fundraising and whatever the process is. And there is no other way. So it's fascinating to hear that story.
I think we developed a pretty unique culture with real collaboration between the science end and the business end. So I think that the business people realize that without high quality evidence, they're not really gonna they're not going to have the best product to sell, and they're not going to make a lot of money. And the research people, we know without good sales, we're not going to have money for research. And so yeah, so
Right.
it's yeah, and it's been it wasn't always like that. I think at the beginning it was very anti, but we found ways to align, and that's been, I think, really beneficial for the research. Yeah.
Yeah, I don't think that one needs to sacrifice the other. I really don't. Maybe, I'm a unapologetic capitalist as well. I don't think that a good product or a good service has to sacrifice business, nor do I think that a good business has to sacrifice good quality material or products. I think they could go
Hmm.
hand in hand, and as long as everybody is aligned with the principles and missions of the store of the business. There again, I felt when I met you and the team that there was a lot of synergy between your ideas and your scientific ideas and the business side. I was impressed. I was impressed.
Oh, thanks.
Eli, then so that 2015 you have it out in the market. That's just the beginning, right? Still, that's not where, oh my god, everybody's ordering Decipher. It took a long time after that. I
Yeah.
as I spoke to you before, I believe I still think the test is underutilized, though more and more people are more practitioners are using it. I still think it's underutilized. There's a 22 genes that gives you this genomic score for Decipher. My question is, why 22 genes? Why not 15 genes or 30 genes? Are there more out there that we just haven't looked at? That eventually maybe the Decipher test will be 36 genes in the future. Why 22 genes? Today's discussion is brought to you by yet another amazing sponsor, Veracyte, the provider of the Decipher prostate genomic classifier. Here's the deal, folks. After a prostate cancer diagnosis, what you want to know is, how is my cancer different than any other? The Decipher test helps personalize the diagnosis a little bit better so that one knows how aggressive their cancer is, because we all know that not every prostate cancer is created equal. I clinically use the Decipher test almost every day as it helps me determine, how is this particular patient in my office, prostate cancer, different than the guy I saw earlier today or different than the guy I saw last week? How is their particular tumor behaving differently or will behave differently? That approach helps with the shared decision making between you and your clinician as to what's next for me. What is the best approach? To learn more about the Decipher test, please visit the link below in our show notes.
Yeah. So we came up with a 22 gene signature. We cast a very wide net. So we used what's called whole transcriptome. So you have the genes in in every cell, it's got the DNA, the same DNA, and it's got the same genes, the same code for the genes. But the activity of the genes in every cell is different, right? And that's why brain tissue and liver tissue they look totally different, but actually the DNA inside them is pretty much the same. So we
Mm.
used technology that and helped develop technology where we can look at everything in the sample. How we came up with 22 genes was really using a machine learning model to come up with the features, the genes that have the most importance for what we were trying to do. We know that there's hundreds or maybe thousands of more pieces of information that are also useful, and we continue to collect them. So future versions of the test will include other pieces of information. So it's not just the 22, but at some point in medicine, you have to lock it, and then to validate something, you can't keep changing it because we're involved in trials that are funded by the National Cancer Institute, and they're trials that take 10, 15 years. If every month or every year it's possible we change the model,
Yeah.
what would you be validating? Like, so that's maybe a limitation.
Yeah. You have to start somewhere.
Yeah, but we use, the future of what we have Decipher, and you're absolutely right. It's underutilized. It does take a long, most physicians, like when you were in med school, for example, did you train on how to use like a test like Decipher? No,
No.
because it wasn't invented, right? So and now people are starting that are going to med school now, they're starting to get actually trained on how to use these things, and maybe later on in residency and fellowship, and that really recent and new. So it takes time.
Eli, let's not reference medical school because then that tells my age, and I want to kind of act like I'm still, 25 or 30. So let's not reference medical school. I'm only joking with you. I'm getting right. Right. So these 22 genes are specific to prostate cancer, right? And for the listener who already have listened to me and other interviews, they know that there's a difference between germline mutations and genetics and germline mutations, and there's a difference between that and somatic mutations and somatic genes. Germline mutations is the genes that were passed on from your parents, all right? So it increases the risk of whatever that was passed on from your parents. Somatic mutations, what we're looking at here, is specifically to the type of cancer you have. It tells you something about the type of cancer that you have. So it's more of the biology, if you will, how it's going to behave or how it's behaving than than the histology. Is a Gleason 6, is a Gleason 7, is a Gleason 9. So it gives you that information as to the behavior of that specific cancer. My first question is, make any corrections that you have to on what I just said. I want to make sure that I get it right, not just be right. And number two is, how is it specific to prostate cancer?
Yeah, so actually these tests are looking at not actually cancer, they're looking at a tumor, right? And a tumor is a
Mhm.
complex mixture of cancer cells, but also immune cells and the different kinds of cells, blood vessels, stromal cells, many different kinds of cells, and they're actually all talking to each other. So what we're measuring with Decipher is that crosstalk between these cells, and really what it tells us is the the tumors whose cancer cells have a greater malignant potential, which means the ability to spread. Because most people don't die of localized disease. As you know, they die they die of cancer because the disease has spread to other sites, distant sites. And that's mostly true. And so this, what we're measuring with Decipher is specific to prostate tumors because there may be many things that cancers, breast cancer and prostate cancer actually share, and lung cancer, in terms of the way that they crawl and leave the primary site and spread to other parts of the body. But the environment that they're surrounded in is a little bit different, right? Because the prostate
Mm.
gland is different than breast tissue or lung tissue. It's a different. It's a different neighborhood. So with Decipher, we're
Mm.
capturing some of that information, and I think that's a nuanced thing, but it's kind of important. In the principle of how we made Decipher, you can apply it to any cancer. With enough data, you can apply it really to any cancer and determine their metastatic potential. But it is pretty specific to prostate, and we've looked at it in other tumors, and it doesn't seem to work in bladder cancer or kidney cancer or breast cancer, for example.
Is it a possibility that these 22 genes, if that's the right terminology, that you use for prostate cancer, that at least half of those same genes are in kidney cancer, bladder cancer, or are they completely different from each other? I'm not even now I'm getting into an
Yeah,
area that I'm not even sure exactly what language to use, but if you know
no,
what I mean.
yeah, so there's like what Decipher is capturing are multiple processes that are going. It's actually what it's measuring is both the yin and the yang kind of the tumor, right? So it's
Mhm.
measuring it's measuring features or genes that when they're at high levels, that's associated with spread. But it's also measuring features or genes that when they're at high levels, they're associated with not spreading, with just staying in the same place, right? That's what we mean by the
Mhm.
metastatic potential, like low versus high metastatic potential. Some of the genes definitely are important in other cancers, actually all the ones that you just mentioned. But the whole signature, because it's a machine learning algorithm, right? It's not just measuring the genes. That signature is trained very specifically for prostate cancer.
So the information that we get, right? So the information that a clinician gets is within a scale between zero to one. So the
That's right.
closer it gets to one is more high risk. The middle, which is about point 0.5, is intermediate risk, and lower than point 0.5 is low risk. So when we get that information, what that really means is that you looked at the genes, you looked at the microtumor environment, and this kind of crosstalk, which this kind of crosstalk. So there's a combination of looking at multiple things to say, yep, this is your score: low risk, intermediate risk, or high risk. More or less, is that what it is?
Yeah, so part of what Decipher measuring, again, we don't totally understand it, but
Mm-hmm.
part of what it's measuring, your immune system. I know I've listened to a lot of your
Mm-hmm.
podcasts, and immune system is really important. So normally, your immune system is supposed to pick out cells that have acquired mutations and say, okay, there's something wrong about this, let's get rid of it. But cancers, as they evolve, they need to learn how to avoid getting killed by the immune system. So part of what I think we're measuring is it has something to do with the baseline state of the host, the person who has the cancer going inside them, their immune system. Again, I don't think we totally know, but I think that's part of it.
You know, I would love to, and I would love to do a study on my holistic and lifestyle protocols, and then looking at the cipher before and after. What I do, so people usually ask me, how do you treat prostate cancer with natural methods? Well, I don't know that I treat prostate cancer with natural methods. What I think I do is I treat the microenvironment of the tumor, right? So if you follow this protocol, it involves exercise, very prescriptive. It involves some sort of dietary things, very prescriptive, some nutraceutical supplements. How do we improve sleep and sleep quality? And sort of if we do all these things, breathing exercises, if we do all these things, I believe that that does something to the microtumor environment, right? And it'd be so nice to do some sort of study, longitudinal study. This is the issue. This is why I haven't done it, because it takes, I used to do studies at Columbia University, and I quite frankly didn't enjoy it. And I didn't enjoy writing grants. It was like I want to work with people. I
Hmm.
want to implement the information. I'm an implementer, an interpreter, and implementer of the science so that people can actually benefit. But that's the thing that I do. I treat the host. It's all about the host. So I would be
So
curious to see how that would.
yeah, Dr. Gio, there are actually a number of ongoing studies, and there's more that I know are being planned where they're doing exactly that. They're getting a baseline measurement with Decipher. We're not only interested in Decipher, we're interested in lots of other stuff, like the whole transcriptome, what's going on with the genome of that tumor. And then they're
Mhm.
getting a measurements after the intervention as part of the protocol. And interventions could be, for example, exercise, different ways of doing exercise and dietary supplements or weight loss,
Yeah.
for example. Yeah, because
Hmm.
the factors, people that get prostate cancer, I'm sure you treat patients, so it's more of a marathon than a sprint for most people. And the factors that affect outcomes, so Decipher can tell you what's your prognosis, what's the metastatic potential of the tumor. But if you have somebody that has a higher metastatic potential, but they do a lot, we can talk about what doing a lot means. You can alter that. If you just go home and just don't do anything, get depressed, you can also alter that, but maybe in a negative way. So I think it's, just
Yeah.
like you go to a really good surgeon, you maybe associate with better outcomes, or a really good center that's typically associated with better outcomes than someone that doesn't know what they're doing. So how good your medical team is, but then all of the other factors, I think where your expertise comes in for people with prostate cancer is what you can do yourself to heal yourself
Hmm.
is really important.
It's patient empowerment, Eli. It's patient empowerment. And there's a lot of talk on shared decision making, for example. Again, that's a good thing, but only if you know what to talk about. Only is if as a patient you're well informed and not looking at crazy things in the internet. So then this is why I have this podcast, right? I want to educate the patients to say, look, talk to your doctor about whatever. Talk to your doctor about the Decipher test. Why wasn't it ordered?
Hmm.
Because for some odd reason, is not. I keep hounding on this. It's just not ordered enough, or any type of genetic testing is just not ordered enough. So oftentimes the patient
But
has to drive that only if they're well informed.
I think, in fairness, though, to physicians, when you have a new technology, the guidelines very clearly state you shouldn't order these tests if you don't think it's going to change your management. And a
Correct.
lot of physicians, it takes time to know the literature and read all of the studies. So they don't even know that it has a chance of changing their management. So they don't order it. So part of that's really just learning about a new technology. And it does take time. And then the other part of it is, as you mentioned before, it takes a long time to have, there's so many different treatment pathways that someone could choose. And they're all, there's many variations. So from our standpoint, we have to do hundreds of studies to kind of cover all the different practice patterns, and we haven't done them, right? So that's also part of it.
Yeah, look, I'm guilty. I'm guilty as charged for over ordering things that perhaps sometimes, I mean, as an integrative and functional medicine doctor, all my colleagues order a lot of things, and I'm always like, why less is more. But if I compare
Hmm.
what I do to conventional medical doctors, I order a lot. I would have a Decipher on a Gleason 6 person in active surveillance. Why? That may not change my management, right? They still could be on active surveillance. But is it possible that is Gleason 6 low risk but high Decipher score, right? So in that particular
Yeah,
scenario, I wouldn't remove them from a Gleason 6. I still think, but I would say, hey, we need to really, this is another reason why you cannot disappear and say, well, I'm not going to see, I'm not going to get a PSA in another 10 years, right? So that
yeah.
information
I think,
helps motivate the patient to be more on it.
yeah. I mean, first of all, I think you're right, and I think the way that you're doing things is the right way. So I think in cancer, again, if you're thinking this is more of a marathon than a sprint, you're always getting a little bit more information that helps you to continuously make better decisions. So definitely, again, what the guidelines say specifically about Decipher for low risk patients is you should be monitored a lot more closely and take those patients off surveillance if stuff changes. So that I think that's
Hmm.
definitely important. And then just from the studies that we've done, but just our customers using the product, and I think that's why when they start using it, is every one of our customers has a patient that had Gleason 6, low volume Gleason 6, that had a very high decipher, and they either took them to surgery or treated them in some other way, and they found out later that the outcomes were that person probably shouldn't have been on active surveillance, right? And so they help that person, right? Because you don't want to
Yeah.
survey people that have a cancer that, I mean, you can basically cure them by getting rid of it. Yeah.
Same thing with it. If it's a Gleason 9, right? For example, it's a Gleason 9, but low risk genomics or Gleason 9. Okay, well, maybe we don't need to go too aggressively. Maybe we don't do hormone therapy if they're going to do radiation after prostatectomy, let's say, which is actually that's a
Yeah,
study. Recent studies has shown that's part of the treatment plan, how it helps with treatment plans. Where okay, this patient low
exactly.
risk, maybe there's no hormone therapy that's needed.
Yeah, I think if you look at the number of people that are on hormone therapy in the US, it's like the same as the population of Chicago. It's some, I don't remember the exact numbers, but it's a huge number.
Yeah.
And and the thing is, as men, continue to live longer, the fastest growing demographic in the US in men, like decile of age, is 90 plus. So they're not the biggest group, but it's the fastest growing. So as they continue to live longer, these drugs have very profound, I mean, this is your whole practice, they have very profound long-term effects on
Yeah.
the brain, the muscles, the heart, and not to mention the sexual aspects and quality of life. So reducing the harms of overtreatment, of doing too much hormone therapy, I think that's an important part of optimizing, doing precision medicine. The people that need a lot, they need to get it at the beginning, and then there's lots of people that probably don't need as much as we currently are giving them.
Right. And to know the difference, once again, as you mentioned, precision medicine, that's the future for sure. But that's even now. Like we don't have to wait 5, 10 years. We could be more specific right now. And that's kind of it breaks my heart when I feel that some men do not need to be on hormone therapy and they are, or they're on it for too long, or and then you can see the
Hmm.
quality of life diminish like significantly, right?
Hmm.
And then I try to help them with
Hmm.
that. But here I am. Hey, make sure to go exercise, man. You got to go, and make it all sounds good, but they're not motivated.
Well, I listened to
They have
your
no desire.
podcast with Dr. Spratt a few weeks ago, and I really that part of just small things that people can do to improve their quality of life while on hormone therapy. I thought that was really important for for to hear that the way that you talked about it.
Absolutely. And I think
Yeah,
it's
the
all within
quality of life
context, not to
issues.
completely.
Yeah.
I'm sorry, go ahead. There's a little bit of a lag for the
Well,
audience just because Eli is in Florence, Italy, and I am here in New York. So there's a little bit of a lag. So sorry for that to the audience, and sorry, Eli. We should be able to cut out some of that, but sorry about that. Go ahead.
okay. Yeah, I apologize for the crappy internet here. Yeah,
Yeah.
what I was going to say, we're also looking at transcriptomic information, so signatures, including Decipher, and how good they are at predicting which patients are going to experience different kinds of toxicities from the treatments that we give them or physicians
Oh,
give
that's
them.
great.
So that also could be important to know what's the risk, so we know if they should get it or not. And then if they're going to experience lots of toxicity, then maybe there's a way to further tweak it to make it more manageable for that person. So those are also things that researchers working in part with us are investigating.
Today's discussion is also brought to you by the makers of the ExoDX test. The ExoDX prostate score is a non-invasive, no DRE necessary, so no finger up, no prostate exam necessary, urine test to determine if you need a biopsy. Now, we all know the issues with the PSA test. It's a great test in my clinical opinion, but is imperfect. So what else is out there to determine, you know what, I really need a biopsy. Unfortunately, there's no other way around it. That test is the ExoDX test. Again, a urine test, pee in a cup, send it to a lab. It gives you a score. If the score is above 15.6, you likely need a biopsy. If it's below 15.6, you may not. So this urine test, the ExoDX test, should be part of the decision making, part of the shared decision making between you and your clinician on whether or not you need a biopsy. To learn more about the ExoDX test, please visit the link below in our show notes. That's great. So let's take it back for a second because I don't want to assume that the audience knows how Decipher really works. So
Okay.
it's not a blood test, it's not a urine test. You
Yeah.
get a prostate biopsy, And then that biopsy tissue, once it's ordered for a Decipher, so your practitioner, your urologist, has to order a Decipher test on that tissue of the biopsy. Then it's sent to a lab, and then that lab analyzes it and gives it a score, genomic classifier score, if that's the way to mention. Same thing happens not only from prostate cancer tissue from a biopsy, but also from a prostatectomy. So when the prostate is removed, your doctor there again can order a genomic test, a Decipher test, and look at the whole prostate and give it a genomic score.
Right.
So once again, no urine, no blood, this is from tissue itself.
That's right. But a question we get
Right.
asked is, do I need to have another biopsy? And that was part of the innovation is we're working off material that you've already collected, right? So the same material used to that your pathologist used to diagnose and say, hey, you have prostate cancer, that's the same material that we use. You don't have to get another biopsy to get a Decipher.
Right, exactly. Eli, how long after a biopsy can you do a Decipher test? So sometimes I see patients who had a biopsy 4 years or 5 years ago, and I'm not sure what the cutoff is. Is there such thing as an old biopsy prostate tissue that cannot be used for a Decipher test?
Yeah, so we've done research studies on samples, both biopsy and prostatectomy samples that were about 30 years old.
Wow, okay.
So technically, we can do it in research. The lab has very stringent quality control for clinical use. So they'll try it. If the sample's available, it hasn't been destroyed, the sample's available, they'll try it. There isn't really a time limit. Again, it comes to how would you use that information? So we've had many patients that started active surveillance, for example, and the Decipher wasn't available in their area or wasn't available. And so we went back and tested them and their physician ordered it. And then I think it's more common on the prostatectomy samples because many patients they'll have a prostatectomy and they think everything's good, and then sometimes the PSA starts to change, but it can be some years after the prostatectomy. So then they get a Decipher, and that helps them to understand the trajectory of the PSA. And with the Decipher, it can really, and there's actually probably more data on Decipher after surgery, so that's where we really started, but it can impact what especially radiation oncologists will do and whether they'll add hormone therapy to the radiation and then also the duration of the hormone therapy.
When I'm assuming at your lab, there's a pathologist. I'm assuming, and they're the ones
Yes,
that
there's
that
several.
do,
Yeah,
they several pathologists. So they do the
yeah.
work. I don't know if they have a prostate, they cut it up. I guess I don't even know what the process is, right? And then they look at it under a microscope. In a situation when they're looking at the prostate, they're literally looking at the whole prostate and the tumors on that prostate and give it a score. How does that work?
No, so you're at your institution, you have the pathologists that first diagnose that cancer, right? And they write a report and it says, in this sample, we found cancer and it was grade group 1 or Gleason 6. And by looking at that report, when you order Decipher, the team at the lab, they know to say, okay, they contact the pathology lab and they say, send this sample. And and then when they send that sample, our pathologists look at it again. And they look at it again
Mm-hmm.
to make sure that there's actually cancer there, but also to select the part of the tumor that we're going to use for the Decipher assay. So there's a specific criteria. We're not just randomly taking a piece of prostate tissue. They actually spend quite a lot of time figuring out what they're experts in it, of course, but figuring out what is the best part of the tumor to take for the Decipher.
And that is the same process for both the actual prostate and prostate biopsy tissue is the same process. You guys order a specific tissue and then you analyze?
That's right. That's right. Yeah, it looks a little bit different as prostatectomy than a biopsy,
Yeah,
but it's
right,
more or less the same
right.
procedure.
And the other samples came back Gleason 6. As we know, there's some error with histology and histology scoring and Gleason scores. and when that's given, when it's given a Gleason score from a pathologist, it's human error. We know
Right.
that. How do you know that you're getting the right tissue? So in other words, if you are getting my Gleason 7 tissue and you're saying, low intermediate risk, how do I know that you're getting the right tissue? Because if you get another sample, it might be a higher risk.
Right.
How does that work?
Yeah. So that's a really good question. So I think the first thing is if we were always picking the wrong sample, or most of the time, then the test wouldn't be any good and it wouldn't validate in all the studies like it has. So I don't even remember how many
Mhm.
studies the test has been validated in, but it's in tens of thousands of patients at this point. So that's the first part of the answer. When you do a prostate biopsy, you're sampling about 3% of the prostate, depending on the volume or the size of the prostate. So large prostates, you're actually sampling less than 3. And we know that we do, on occasion, some tumors are missed. But overall, the template biopsy and now with targeted biopsies, I also got to listen to your interview with Dr. Taneja. It was a really great podcast also.
Thank you.
With targeted biopsies, we're better at finding the right tumor. So nothing is 100% in medicine, is I guess what I'd say. But I think the studies that have been done have shown that it's sufficiently good the way we're doing it. And so we're actually always looking for ways to improve it, but you can't, you're biopsying somebody, you can't take the prostate, look, and then put it back in. I mean, no one's figured out how to do that yet. So, and then you don't want to make,
Exactly.
100 needles through the prostate either, right? So no one does that. So I
So
would say on average, the tests work.
even from the scores, let's say 4 came back Gleason 7 out of the
Yeah.
12. Are you ordering or 4, or are you ordering one of those Gleason 7s?
Yeah, we're ordering the core that has the highest grade and the biggest amount of tumor. And that's not always the one that will have the highest Decipher score. We know that, but it's about, you know, correct about 90% of the time. There is a lot of heterogeneity in prostate cancer and tumors, so it's very common that there'll be multiple spots of cancer, but not all of it actually matters from a clinical perspective. So if you have a Gleason
Mm,
9 and there's a bunch of Gleason 6 or grade group 1, you're not making your treatment decisions like factoring in the Gleason 6. You're focused on the Gleason 9. And most of the time,
right.
we're correct with Decipher. And it would be better to test every core. I think that would be better. But the medical system, it still would be a bit cost prohibitive. So can't do
Mm.
that.
But even I would want to, at minimum, I would want all my Gleason 9s tested, not just one of them. Because maybe what if each one gives you a different score? They're both Gleason 9s, but one is low risk, the other one is high risk.
Yeah, it happens less than you would think that the one that we test is going to give a low risk score and the other ones would give high risk scores. It has happened in research studies. We have seen it. But again, it's, nothing is perfect in medicine, including a radiology report or who depends on who does you're lucky to have Dr. Taneja do biopsies, but most people don't have that skill level, right? In the country, they don't have the
Correct.
access to
That's
that.
right.
Yeah.
That's right. That's right.
Yeah.
That's the
So
other issue. If I'm a patient and I see 4 Gleason whatevers, again, 12 core biopsy, there are 4 Gleason 7s. Just keep with the example. Can I say, hey, cost aside, forget about cost. I want all my Gleason 7 sent for Decipher test, Decipher score. Can I do that as a patient? Our next amazing sponsor is XY Wellness, a company I know a little bit about as co founder and medical director of the company. XY Wellness is a company to help men renew, rebuild, and reclaim their health, their bodies after a prostate cancer diagnosis. XY Wellness is a lifestyle company that helps provide a no nonsense roadmap to health and wellness in men after they are diagnosed with prostate cancer. The hope with our program and what we see with many of our members is that men after prostate cancer tend to thrive, not only survive, through our program. To learn more about XY Wellness and its roadmap, please visit the link below in the show note.
Yeah, we have had,
What is the possibility? I've always wondered this of, there's 12 samples in a biopsy, right?
right,
4 of those samples came back Gleason 7, whatever, 3
right.
plus 4 or 4 plus 2, doesn't matter.
People that do that. Of course, we can't, there's rules, compliance rules around insurance. So, we can't bill for Deciphers and we don't do that. But we have had people that are willing to do that. And then I think actually more common, we our business is a service business. We service physicians. So if a physician comes and says, I'm just not sure about it, I'd really like you to test this other core. Our lab and medical directors have been really doing the right thing. I think also being generous with allowing the customer to test another sample. So yeah, they want the physician to feel comfortable making a decision with the technology, and so that happens from time to time.
Is the future of genomic testing? Is it going to, the way in my mind, right, as a clinician, the way I see it is you put all this data together in some sort of AI system and it gives you something, right? So put a genomic score, PSA velocity, PSA density, all the things that matter in terms of the possibility of progression and even
Yeah.
possibly therapeutic approaches. What's the future as it relates to genomic testing? What do you think is happening?
So I can tell you what we're working. So all of those things that you mentioned, and I've heard you speak about them in other podcasts. I definitely, those are part of the future. What we're working more on the near term is we identify two people that have a very high Decipher, a high risk score. We further want to characterize their biology to understand which person is going to do better being treated with surgery, which person is going to have better outcomes treated with radiation. And when we say better outcomes, like better oncologic outcomes, but also quality of life, toxicity, etc.
Mm-hmm.
And that goes beyond to all the different drugs, different kinds of hormone therapy, chemotherapy. So we have a lot of very active research. You may have heard of the grid, and
Mm-hmm.
that's where that's happening. So it's all this other
I
information
just
that
I
we're
just saw
collecting.
I just saw. Sorry to interrupt. I just saw a grid report from a patient like yesterday, so
Okay.
it was really cool. Do you mind expanding on the grid reports and what's a grid, and
Sure.
again continue on where it's going in the future?
Right. So we had Decipher, which tells you the metastatic potential of the tumor. And then the grid is a further biological characterization of the tumor. So it's like the we're trying to find for every patient the Achilles heel for that specific tumor. So the grid has a number of other signatures like Decipher, and some of them read into the sensitivity to hormone therapy. They read into which patients benefit from higher doses of radiation versus lower doses, and also with chemotherapy like docetaxel chemotherapy. So that's really what the grid is about.
I look forward to that. What's the utilization of technology and artificial intelligence with the Decipher test? What's the future there?
Yeah, we've been fortunate, through all of this hard work, and again, I have to emphasize the village, right, that brought up Decipher. So it's really been a extremely productive collaborations with researchers now from all over the world. And they're the ones actually that deserve most of the credit to making it a great test. Some of them you've interviewed on your podcast. But the company has amassed very large amounts of data through all of this testing. And so, yeah, that's the learning how to use AI and create. I mean, Decipher was created using machine learning, which is a form of artificial intelligence, and a lot of this is like marketing kind of stuff. But using the more data you have, the more sophisticated the models can be. So that's a very fun and challenging from a scientific perspective. And then let's see how it is actually going to be beneficial to patients. But I think what you've outlined before and your kind of vision of all of these AIs that are hoovering in tons of information, that's definitely going to be part of the future. But we have to walk before we can run, because these models
Sure.
can spit out total garbage too.
Well, garbage in, garbage out, right? So that's why
Yeah,
we have to be very careful with the information that we put in, including the
exactly.
information, like we said before, with the biopsy that's sent to you and,
Right,
all these things. We have to be
exactly.
very intentional so we could get the best results and the best data from it. Dr. Eli Davicioni, did I pronounce your
You
last name
pronounce it
correctly? I feel like I didn't.
così. Yeah, Davicioni. Yeah. But it took me
Davicioni.
like
You would
15
think with
years
a
to learn how to pronounce my name. So, like, as a kid, I didn't know how to pronounce it either. So, don't feel bad.
You would think with a name like Giovanni, I would know how to pronounce Davicioni, but no, of course, I'll get stuck on that. Dr. Eli Davicioni, one of the developers with great team of people behind the scenes on the development of Decipher, a test that's used pretty frequently now because of the research, because of the academic institutions that support it and utilize it and written great papers on. So, Eli, thank you so much for being on. I can't tell you how much I appreciate it, knowing that this is your first podcast you've ever been on. So,
Yeah.
congratulations. Hopefully, it's not the last. And I hope to see you soon.
Yeah.
What
Hopefully,
is
I have a bit
last
better
final words
internet
from you?
connection, better interconnection next time. Because the
No, you're.
delay, it's hard to. It was nice to talk to you in person. Maybe I come to New York and we talk in person. It's maybe easier like that.
I would love that. Final words from you.
Final words. It's ominous. Yeah, there's still so much more to do. We want to do, sorry. There's a lot more that we want to do, and there's a lot more to do. And I feel really fortunate, and I think patients should know that we're in a very good time. So there's never a good time to get cancer, but it is actually becoming a disease with precision medicine that is something that that you can really manage through. And again, it's more the marathon than the sprint, for especially for people with prostate cancer. Yeah, find the right people to help you, and yeah, and I think using technology like Decipher, I think overall is pretty helpful.
Well, thank you so much. Everyone, thank you for listening to this very special episode on genomics and prostate cancer, particularly the Decipher test, which you probably heard a lot of. It's been making its waves all over the internet, a lot of research papers written on it. And, it's ultimately about you being empowered, you being part of the decision making, but you can only be a part of that decision making based on the information and the data that you have. So you want good data to make decisions and to be part of that decision share making is the empowerment of the patient. So thank you all for listening. I trust this was valuable to you, and so that you can have great discussions, learn yourself, and have great discussions with your practitioner. Eli, thank you so much. I really appreciate you. Everyone, this is Dr. Gio signing off. I'll speak to you next time. Much love. Tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Gio Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. And now for a brief disclaimer. This podcast is for general information only, and we're not forming a doctor-patient relationship through this medium. The use of the information and all links associated with this podcast is at the listener's risk and is not to replace medical advice from a physician or a healthcare practitioner. Lastly, thoughts and opinions related to this podcast are my own and may not reflect the views of any institution or organization I'm associated with. I'll see you next time.